Well, then let's go ahead and talk about the money. The part you've all been waiting for, right? How's the money going to work? So, you know, the money thing, the carve in, carve out question is raging all across the country. And all these conversations going on about, well, we should, you know, carve it in. Well, no, we have to keep it carved out. So what we do know about carve-ins, in which all of the money goes into a health plan, is that it's been infrequent, and when it has been done, it's been disappointing. So New Mexico was the only state that did a complete carve-in of their entire mental health program into health plans. And that was not a successful initiative. You can see one of the things that happened is that they carved it into 3 health plans, and then those 3 health plans each turned around and carved it back out again. So now you had 6 entities doing what once one entity was doing. And so not a very successful strategy. And eventually, after the feds told them that they couldn't do that anymore, they reorganized the whole thing. Tennessee started out in their Medicaid managed care program carving it in very briefly, then carved it out, and then recently carved it back into one regional plan and said that the results were disappointing. And the comment that the commissioner in Tennessee made to me was, you know, we gave them the money, but nothing changed on the ground. Nothing changed in terms of how services were delivered. And then University of South Florida has done a study specifically looking at services for children and youth and found that carve-outs were better. That said, carve-outs are not without their problems. So they have been seen as a huge barrier to integrated care, and that is true. It functions that way in most states. It begins with the fact that most states are underfunded to deliver the services to the population with the most serious and severe needs. We have carve-outs in 23 of the 28 states that have Medicaid managed care, and those carve-outs nationally have been driven by an assumption of a 10% penetration rate into the Medicaid population. Now, I want you to think back to the data that I gave you when I last met with you. 26% of the general population is likely to have a mental health disorder in any given year. If you're on Medicaid due to disability, that goes up to 49%. So if the population on Medicaid with a disability is at 49% and everybody else is at 26%, then tell me how 10% is enough money for serving 10% is enough money. It's not. Does it surprise you guys? So that means that when people start having this carve-in, carve-out debate, what happens is that the people who are involved in the services in quadrants 2 and 4, where you're in the specialty, mental health, and or a substance use system, are concerned that what will happen is that if it gets carved in, those folks will lose services in order to deliver more services down here in quadrants 1 and 3. And one other thing about the specialty system is the documentation requirements associated with it, because almost every state that I have worked in has at least a 20-page packet of enrollment documentation that needs to be filled out. Now, let me tell you, in primary care, where there's a different patient being seen every 15 minutes to half hour, you really don't have time to take that warm handoff from the doc and then say, excuse me, the first thing we're going to do here is 20 pages of paper. It doesn't work. So the documentation requirements, in most places that I know, people are not billing into the public mental health system, even if they could, because of the documentation requirements, the barrier that represents, and the impact on productivity. So, just a little bit more about being underfinanced. This is an analysis that took all of the states and all of the money that they have for mental health services, and then did an analysis that said, let's use the prevalence data and the population data from each of these states to say, how much money per person would they be if everybody were serving everybody they ought to serve? So essentially got rid of the differences in the rules among the states and just said, This is the expectation on an apples-to-apples basis of how many people you might serve based on your population. How much is that per person? You can see here that the top 10 average, which seems to be mostly East Coast states, has an average revenue of $4,472 a year per person. You will see circled down at the bottom the state of Washington, which has an average of $2,051 per person, or slightly less than half of that amount of money. So it's just another way of thinking about the underfinancing question, which is seeming more prevalent in West Coast states, and I don't know why that is, just because we got here later or something. So all of this said, we need a new paradigm. We need a new way of thinking about the financing, because none of these old models are really working well for us. So let's start by seeing what's out there in the field that we might be able to use. And the first thing we want to think about is the medical home pilots. And you'll remember that I said to you last time that what they're looking at is this layered financing system of fee-for-service with a case rate and a shared bonusing system. Why not add the purchase of behavioral health services as a service within the primary care setting, the patient-centered medical home, and pay for it through that flat rate, because it really doesn't lend itself very much to CPT-coded kinds of activities. So that's one idea. We see that at work in Minnesota right now. In Minnesota, the Diamond Project, which is an impact model implementation, is the primary care practices, and there's 90 primary care practices in this particular project, are getting a monthly case rate for delivering the behavioral health services in primary care. They're getting it from all of the payers in Minnesota because they all came together and agreed on a model and agreed to do it this way, to make a monthly case rate. And it's generally, it's being paid out of the healthcare side, not the mental health side, because they believe that's where the cost and quality impacts will happen, is on the healthcare side. So we've got some folks in Minnesota who have a good idea that seems to really be paying off. In Washington, one of the things we can think about is the GAU project, and the fact that it's a model in which the transition from primary care to specialty care is a connected, stepped-up process. People start in primary care, step up to specialty care, rather than coming in some other door over there and coming into specialty care. So is there something there that might help us think about a new paradigm? And then the last example, being the all healthcare is local example, is Washtenaw County, Michigan, which has had one of the other most well-known integration initiatives around the country. And they negotiated through a waiver a global budget for the entire Medicaid population in the county, consolidated all of the money, the mental health money, the drug money, the medical money, and established a community corporation that is jointly established by the County of Washtenaw and the University of Michigan Medical Center, excuse me, and a community board, and that board governs the financing of the Medicaid system in Washtenaw County, and they decide where and how the money is going to be spent and where their priorities are, so you don't have separate silos that you're having to work back and forth across. We're going to be shifting the way the money is paid out anyway, so now's the time to be thinking about this. One of the things that is very much on the minds of people around the country is bringing people in Medicaid who have been on fee-for-service into managed care. And so you see this is going to roll out soon in California, where they have an 1115 waiver. They're going to be bringing all of their fee-for-service folks into Medicaid managed care. Excuse me a moment. And then there's the question of dual eligibles. One of the conversations that's going on around the country, and again, California's got this in its waiver write-up, is to do a new kind of financing structure for individuals who are both Medicaid and Medicare. And the idea, quite briefly, is that Medicare would make a capitation payment to the state, who would put that together with the Medicaid capitation payment, and together that would be one payment to a health plan through both financing streams together, money blended. They don't have to sort it and bill it in different ways. The bulk of the savings we think will come from the Medicare side, and these would be governed by the state and the feds sharing in the savings if you put all the money together in a new way. Now, if you think about that, you go to all this work to get the Medicare and the Medicaid money finally together, and you may remember that I told you the last time that 52% of people who are dual eligibles have a psychiatric comorbidity. Nobody's going to carve out that mental health benefit again. That would not make sense to do, because you've got all of this complexity that you need to coordinate in a single way. And the implication of that, if you take a look at the analysis that we did here using one RSN in King County, in Clark County, that the disabled population represents 11% of their enrollees, but 52% of their revenue. So if there is a dual eligible plan coming up, that's going to have a big impact on county and regional mental health authorities because of the proportionate share this represents of their revenues, and that's simply because of the rate setting structure. So how do we share this money out? I've had this in my files for a while, and as I was working on the California continuum that we just looked at, I pulled this back out again. This is a very complex document that was put together by CARE Oregon, the safety net health plan in Oregon, as they were thinking about working with the carve-out mental health authorities in Oregon. And essentially what they wound up suggesting was that as you move from mild to severe mental health system complexity, that there's a shifting line, see it's that red line here, that begins to change how much of the care is being purchased from which funding source. So think now back to the continuum that you just saw from California, mild, moderate, serious, severe, and think about, well, what would happen if you overlaid something like this on those conditions and thought about who might pay for what. And in a simpler version, this is a simpler version of that other picture, what we would then have would be a system in which the general health care system funds the mental health and substance use services for the mild and moderate care, which would mostly be happening in primary care settings. So the current health care funding would be the source for that new investment in mental health and substance use services, and the current mental health and substance use services would continue and be focused, very focused, on those at the most serious and severe levels of care. And so now if we come back around to the financing paradigms that we just touched on a little bit the last time, you'll remember this picture of the case rate, the layered case rate for medical homes with fee-for-service and the bonus. And this could include the way to do this, the mechanism for this would be to do this through the diamond case rate model, having that be a part of that wraparound payment. Which brings us to accountable care organizations and why they're so important, because there's this differential payment method and there's those bundle payments to hospitals and physicians that I mentioned to you the last time. The accountable care organization is seen as the place to hold all of this, and these are provider-driven organizations. They are not the same thing as health plans. I gave you some detail about this the last time, and I'm going to jump ahead to this picture, which is, this is the way the money works now. Comes out of the health plan, into various primary care clinics, to specialty clinics, to hospitals. And this is the way the ACO would be expected to work. then, so that the money would come from the health plan, but then within the accountable care organization, all of this financing would be internal to the group, the provider group. And the provider group, what this would do would be to pull together the incentives that are being built for hospitals and specialists with the incentives that are being built for primary care practices, so that everybody is operating on the same set of assumptions and goals about quality of care and lower total health care costs. And one of the key ideas that has been talked about with the accountable care organization is that if you are a medical home, if you're a primary care provider, you can only be part of one ACO. Unlike what happens right now in some states where there are a lot of independent practice associations and a practice will join every independent practice association. That's not the model here. The model is that the medical homes will be the foundation of these ACOs. Specialists and hospitals may belong to more than one. So the way the ACO gets paid, if you think about the health plan here, is there's a capitation associated with the person. And when the person chooses their healthcare home, by extension, they've chosen the ACO, because the healthcare homes are the foundation of that ACO, and that's what would trigger the payments in. The question then arises, as you think about that future, of how the mental health and substance use system fits into this new ecosystem. And we know from long experience that when change happens, just staying focused on what it is you're doing today doesn't prevent you from ending up at the bottom of the food chain. And so we want to avoid that happening, because it's so important that mental health and substance use services be a part of this new future. And that means that we have to be on top of these many wheels that are turning, all of these levels of changes that are happening, and all of the places where policy is going to be made. And this brings then the question, because in most parts of the country, the system operates through county and or regional authority structures. And the question then is, are those authorities ready? The answer is going to depend on the state, first of all, because there's so much variation across the states. But even within the states, there's variation among the RSNs in Washington State. They are not all the same thing. They are some more ready than others to think about living in this new future and thinking about this. And I think that if they are not responsive to moving in this direction, there's going to be a huge push to shift back to a carve-in. Say, okay, then we'll just put all the money into the health plans. So if they cannot demonstrate that they're supportive of becoming a part of this future, they are at risk. That said, about the RSNs, I want to say something about the counties, because the RSNs are made up of either single counties or aggregations of counties. And counties are always going to be important partners in doing this work. I take you back to community, to that community piece. That's always got to be a part of what you are working with. All healthcare is local. So counties are the ones that have the health departments. Counties have the criminal justice system. Counties have a convening and problem-solving role, and they also, in this state, happen to have a 0.1% sales tax devoted to mental health and substance use services. So the county is always going to have to be a part of that all healthcare is local discussion. And we need to be thinking about that as we move forward. And one of the nice things that the Transformation Grant has organized is an opportunity with the Washington Association of Counties for me to present this exact same material that I've been presenting to you, beginning with a meeting in July, where all of the health departments, RSNs, human service coordinators, all of those county folks are going to be invited to participate in this discussion and to learn about some of these ideas that are rolling out into the future. We'll have an interesting conversation there in July, and then I'll be meeting with them again in September to replay today's training session. So I'm not going to take questions now because Richard is here, and I want to get his presentation up onto the screen. And investment, prescription drug primary care payment reform, consumer-centric health record banks, and a health insurance exchange for small businesses. Sound familiar, like the stuff we've been talking about in these two sessions? He's designated the State Health Information Technology Coordinator. He is a licensed psychologist and experienced healthcare executive, having worked in the public and private sectors in both Washington State and Colorado. Received his PhD in clinical psychology from the University of Kentucky and is a licensed psychologist here in Washington State. And he's going to tell you about what the state actually has rolling about payment reform. Richard.
Good afternoon. Can you hear that? Good afternoon. Good afternoon. Is that better? All right. So thank you, Barbara, for that introduction. I appreciate the opportunity to come here. There's lots of familiar faces here. So I appreciate the opportunity to come here and talk about what we're doing right now. You also have Jan Norman, I see in the room, who is running the DOH Collaborative. So if there's questions about the clinical part of the collaborative, that Jan's the person to talk to around there. We're responsible for the payment reform part of the collaborative, and that's what I'll talk about today. So you heard from Barbara that incentives matter. And incentives in the healthcare system matter because behaviors are going to be driven by incentives and going to be driven by what you get paid for. And this is just sort of a way for me to demonstrate or show you why incentives matter in the healthcare system. It's just a little cartoon. I just find it, and I kind of like it. It's a doctor who's talking to a patient in the exam room, and he says, "First, we're going to run some tests to help pay off the machine." That's a lot of what, it's a funny way to look at it, but people will do what they get reimbursed for. And we found that over and over throughout the medical care system. And so that's why doing something different with how the incentives are aligned for primary care and to support primary care is really important as we move this work forward. So we are working on a multi-payer medical home reimbursement pilot. That's a whole lot of words there. There's a lot of reasons why, and I think you all know the issues around cost trends. Just as an example, in the state of Washington, healthcare is in the year 2000 was about 20% of the state budget. In 2005, it was about 25% of the state budget. That 5% of the state budget is a huge increase because what it means is that there isn't enough, it's taking money away from things like education, transportation, public roads, and those other services that are necessary to support the state. It's leveled out now at about 28% of the state budget, but everybody knows that in the private sector, healthcare is also increasing higher percentage of costs for employers. It's 16% of our GDP currently. It's scheduled to go to about 20% of our GDP within the next few years. It's driving employers out of the healthcare business. At the same time, there's lots of studies and data around the fact that quality in healthcare isn't associated with more costs. So there's a lot of, you've talked about or you've heard about the Institute of Medicine. The Institute of Medicine has said that there's about 100,000 deaths a year in hospitals due to medical errors. The Agencies for Research and Quality says the same thing, about 80,000 to 100,000 deaths per year due to medical errors and patient safety errors. There are a lot of issues around the quality of healthcare. RAND did a study several years ago that evaluated the likelihood that you're going to get evidence-based care, and the likelihood was about half. About 55% of the time you're likely to get evidence-based care when you go to the physician. There is a article that was floating around last year that was a required reading for everybody in the Obama administration by Atul Gawande that talked about the differences in two Texas towns, McAllen, Texas and El Paso, Texas, that one community spent a whole lot more money in Medicare expenditures than another with no difference in outcomes. There's a whole bunch of studies like this that there is no association in communities between the cost, how much is spent on care, and the quality of that care. So that's why doing something that is evidence-based and that improves the overall outcomes is really important. And a lot of that evidence points to enhanced primary care in the medical home. Like I said, the current payment system does not support this. There's a lot of things right now in the payment system that physicians don't get reimbursed for. They don't get reimbursed for coordination of care, for making phone calls with patients, for emails with patients, for coordinating care with hospitals and for specialists. Those are the things that drive better outcomes, but don't necessarily drive better reimbursement for physicians. The other piece of this that's important for us is that it's got to include multiple payers. And the reason it's got to include multiple payers, you've heard a lot of examples today about what we call single payer pilots. Those are pilots that may have been run by a single health plan, a Blues program in a community. Those are effective, but for the most part, they won't be a large part of a single provider's practice. Unless there's a really, really dominant player in a market, you may get 10%, 15% of a provider's practice, and that's really not enough of a provider's practice to really change the way that provider provides care. So the other issue is you've got to get multiple payers involved, which then also increases the complexity, and then also brings the states involved, because in order to get payers to participate in something like this, when you're talking about payment, you have to avoid the antitrust issues, and the only way to do that is by having the states convene and oversee that activity. And so that's why you see a lot of states leading these activities. Examples are Colorado, Pennsylvania, Rhode Island, Vermont. Those states are well ahead in their payment reform pilots, and they're all led by either the state governor's office or the Medicaid agency or some other portion of the state agencies that are leading those efforts. This is a little bit of the legislative background. You can see that there's legislative history around that. The authorizing legislation for us is 5891. It directed us to run some multi-payer pilots. It also gave us a little bit of antitrust protection, which is also critical for this, although it still needs to be actively overseen by the state. The other thing I'll talk about real briefly at the end is a bill that was just passed last year about accountable care organizations. You've heard a lot about that in the last few days. But we do have a bill that directs us to implement a couple accountable care organization pilots. So I'll talk about where we are with that also. So our activity around the multi-payer medical home pilots is twofold. One is the collaboratives that Jan is running in coordination with the Washington Academy of Family Physicians. And those have 33 practices participating in how to do a medical home. All the clinical aspects of what a medical home is and and the research and the evidence around how to achieve a medical home. The other piece of it is the payment reform side. So we have a participant group, and we call it a participant group because we didn't want to call it a work group or boards and commissions, because at the time there was a lot of activity around boards and commissions. So we have a participant group. We convene it and do this in facilitation or in coordination with the Puget Sound Health Alliance. The Alliance is a nonprofit that was started about 2 or 3 years ago out of King County. A lot of Puget Sound area purchasers participate in that. All the health plans participate in that. And it's like a purchasers coalition or a healthcare coalition of purchasers, providers, health plans, and consumers. They do a lot of performance reporting. In fact, the original setup for that was to have all the health plans contribute their claims data so that we have a consistent method through which to report performance by providers in the Puget Sound area. So we participate in that. One of their targets is to initiate and develop a multi-payer pilot. We've had a payment reform summit last October. These activities are very, very complicated. And of course, in the budget situation that we had a couple years ago when the bill was passed, we didn't have any money for it. So we got this direction without any funding to go along with it. What we've been able to do is be able to get a lot of very key technical assistance from other organizations and foundations. The Alliance has a Robert Wood Johnson Foundation grant to hire a project manager and to get some technical assistance from consultants, from experts in this field. And then Washington State was one of 8 states participating in an Academy Health Commonwealth Foundation technical assistance grant. I tend to use a lot of acronyms. I apologize for that in order to save some space. But we do have a technical assistance grant from Academy Health. 8 states are participating in that, and through that we get access to some pretty good consultants who are working with other states on projects such as this. In fact, one of the consultants is working with Massachusetts, and Massachusetts is about probably 2 to 3 months ahead of us, so it works out really well because they resolve something and then they give us the materials that they've just gone through and approved, and so we're able to use them and take advantage of that. So that works out really well for us. I'm not sure what they get out of it, but we really like it. So this activity has been very important. The reason we need to do a multi-payer pilot is because you have to have meaningful and proportional incentives and payment structure. Like I said, if you do a single payer pilot, you may get 10 to 15% of a provider's practice. That's really not enough to have them really transform how they do medical care. If you do a multi-payer pilot, you can probably get over 50% of that provider's practice. And if you get over 50% of that provider's practice, they're going to pay attention to that, and they can really do something that's really transformative and different in terms of how they deliver primary care. So with this, we think we can get over 50% of a provider's practice. It enables them to really make some substantial changes and then sustain them. We do have an issue, as most states do, around Medicare and Medicare's participation in these types of pilots. And I'll talk about that a little bit later when I talk about the fact that Medicare is now has a solicitation out to participate in some states' pilots. But when you do a multi-payer pilot, you increase the complexity and the challenge. It's been a real struggle to try to get 8 payers together to agree on a payment methodology. And I'll talk about that a little bit more. It also increases the complexity around the antitrust issue. So that becomes a key issue, again, around antitrust. So a couple things that have helped us as we move forward with this. We consider this research and development. We've been able to convince the payers that this is research and development, even though they still are interested in a return on investment. So getting a return on investment has been still very, very important to us, but we're also able to convince them that this does have some public good, and there's some research and development aspects to this which helps them justify their investment in this. This is an early step of a transformation of our healthcare system in terms of how our healthcare system is paid for. The interesting thing is, and I mentioned the payment reform summit we had. The easy thing to say is we need to do something different than fee-for-service. So what else is there from fee-for-service? You've heard about some options, but capitation always comes up. But if you ever talk to a group of physicians about capitation, they have this immediate reaction to capitation from the late 80s and 90s around a capitated system. So you've got to work that a little bit differently in terms of how you develop a capitated system and then how you move towards a capitated system through these interim steps. This pilot is different than other pilots that have been developed in other states in the fact that we are basing this pilot on defined outcomes. And the outcomes that we've selected are reduction in avoidable ER use, reduction in avoidable hospitalizations, and then meeting quality metrics. Some basic quality metrics, we set a threshold at which if you achieve this, then you're eligible for the savings or the shared savings or for the outcomes, but you also have to reduce avoidable ER and avoidable hospitalizations. And I'll talk about that a little bit more when I talk about the outcomes. So we have all the health plans participating. We have 3 national health plans participating, United, Aetna, and Cigna. We have the 3 locals, Group Health, Primera, and Regents. And then we have the 2 Medicaid government programs, Molina and CHBW. So all of them have been participating from the beginning, and they've all been very active in terms of how they've participated. A lot of especially the national health plans are participating in pilots in other parts of the country, so they have been helpful in terms of bringing us their learnings from that, as well as some of the documents. For example, participation agreements have been helpful as we move forward. We have a practice selection process that we're we're developing right now. We're in the phase right now where we're trying to nail down all the details and then begin to recruit practices probably in the next few months or so. So we have a preference for practices that are participating in the collaborative, although we also allow for participation in previous collaboratives or NCQA accreditation around a medical home. NCQA accreditation is fairly expensive for practices, and currently in Washington there's really no incentive for them to do that because they don't get paid any differently. So I think there's only 1 or 2 practices right now that are NCQA accredited. The other piece of it that we're going to be requiring is a plan of action that describes how they're going to meet these outcomes, because we really want to make sure that the practices are set up to succeed and therefore understand what it's going to take to hit these outcomes. Okay? So we have some core competencies. What we found in looking at the literature is that the first 2 of these are very, very key in achieving these outcomes of reduced avoidable ER and hospitalization use. The single greatest component of what a practice can do to reduce ER and hospitalization visits is to extend their hours and provide access to them for their patients. So email access, other types of outreach, things like that are going to be important. And we know enough about what makes a good medical home that we're able to make recommendations to the practices about what they need to do to achieve these outcomes. We're trying to balance the description of how we do this and what we think is going to lead to success with not being prescriptive with the practices and say, you got to do this in order to achieve the outcome, to give them some flexibility. So our way of doing that is providing them some core competencies and evaluating them in terms of their readiness for selection on these core competencies. So down to our payment models. We have 2 payment models that we think we're going to pilot. You see this one's Plan E. We started with A and B, and then we went to C and D, and we finally settled on E, and I think E1 and E2, and we made that E. I think this is pretty straightforward. Fee-for-service, the current fee-for-service system, you get reimbursed on that, and then we're going to add a care management fee. It's called care management fee, case management fee, a lot of different things. We're going to call it a care management fee, and then we have shared savings on the back end. We're going to run this pilot for 3 years, and we have 2 evaluation periods, first at 18 months, a second at the end of 3 years. We have a tail in the 4th year to be able to make the payments for the 3rd year results. This model we think is going to be more attractive to smaller and medium-sized practices, not the big, large multi-specialty clinics like Polyclinic and Everett Clinic and places like that. Smaller practices that we think need the capital investment to be able to develop the core competencies around a medical home. We do think that there's going to be a minimum size, and it's probably going to be around 4 physicians or 4 providers, about 7,000 to 8,000 patients, because we think there's some economies of scale around some of the things you need for a medical home, like a nurse care manager. A single doc office is not going to be able to hire a full-time care manager with the amount of money that we're going to be providing them. So we think there's a minimum practice size of about 4 practices. This pilot will provide additional revenue to practices. So that care management fee is on top of the regular fee for service and will provide some additional revenue to practices to capitalize their investments in a medical home. We think all the payers will participate in this. The scale and scope of this is determined by how much that initial investment the payers are willing to make in a pilot like this. So we think this pilot is going to be about 40 to 50,000 covered lives, someplace around there. In terms of the commercial market, about 5 to 7,000 in terms of the Medicaid managed care market. We think it'll include, or it should include, the payers, the health plan's self-funded business also, because that's a critical component. Especially the national payers, the United, Aetna, and Cigna are about 90% self-funded business. Even the local payers, Premier and Blue Cross Premier and Regents are about 50% self-funded. So that's going to be an important part of the inclusion of these types of pilots. So the outcomes are ER and hospital use, and there is a payback portion of this if the outcomes are not met. And it's up to 50% of that additional investment that we're making to the practices. That if the practices don't meet their targets, that they'll be liable to pay back up to 50% of that additional investment, not of their current revenue, but of the additional revenue that they've gotten. And I'll say a little bit more about, in details about those outcomes. So the second model is Plan A. This is a model, the major difference is that it's revenue neutral in the sense that this doesn't provide any additional revenue to practices. So it entails a fee-for-service reduction, and then that's made up in a care management fee. So the practices will get about the same amount of money that they got before, but it'll be in a different form so that they're able to use it in a different way. So they have some flexibility about being able to provide some of those other medical home types of activities. This is primarily intended for larger clinics, the clinics that have already made the investments in an EMR, clinics that have already made investments in registries and in a nurse care manager. And what they're looking for is the shared savings on the back end, that they're going to be able to demonstrate that they're going to reduce hospitalizations in ER, and then they want a portion of those savings. We think it will include most of the payers. We think all the payers will participate in this. The discussions that we're having is mostly with the national payers because they're the ones that are involved in other pilots throughout the rest of the country, and this is an unusual model for that. Most of the models will provide some additional investment, but it's also unusual in the sense that most of the other pilots in other states provide those investments for more process-oriented results. NCQA accreditation, meeting of quality metrics, none of them right now that we know of have the payments strictly tied to achievement of specific outcomes. So we think that's a different pilot, and we think it adds to the discussion nationally about what's going to work in these types of pilots. There are allowances that in Plan E and Plan A. The Plan E, remember I said that there's an additional investment by payers. So before we do shared savings, the payers recoup their investments, and then beyond that, if there's savings beyond that, that's shared 50-50 with the health plans, or with the providers. In Plan A, it's the same except the opposite. So providers will have made investments to become a medical home. The first step at the end of the evaluation period is to have the practices be able to recoup some of their investments, and then beyond that, we'll share savings with both and split them between the payers and providers. So let me talk about what the outcomes are a little bit more. So I mentioned they're on avoidable ER and hospital use. So the estimate in most of the literature is that about 60% of ER visits are avoidable. So our target, our overall target, is to be able to get a 30% reduction in those avoidable ER visits. Now that may sound high, but what we also looked at is if we model the amount of investment that the payers are making, and what's that break-even point where they recoup their investment, we model it at about 17% reduction in avoidable ER visits. So if you take 17% times the 60% that are avoidable, you get about a 10% overall reduction in ER use. And everything that we've seen in terms of the literature on medical homes and on this research says that that's an achievable target for providers. So we think we've been able to find that spot where the payers agree to make an investment, but there's some accountability for it, and that providers have something that's achievable for them. And that's been sort of very, very critical in our discussions about this. We've gone back and forth for months about putting up, from the payers putting up upfront investments. They started with, we don't want to, in this economy, we can't have any additional investments, we don't have any more money, to being able to say, yes, we will do that for some outcomes, in exchange for some outcomes. So we've gotten to the point where we do think we have some outcomes that are achievable for the providers. Reduction in avoidable hospital use, we target a 10% reduction, and the minimum target is a 2% reduction. But remember when I talked about the break-even point? The break-even point only includes the avoidable ER visits. You don't have to save anything on hospitals to break even if you achieve 17% reduction in avoidable ER use. Then you break even, and then anything else beyond 17% or any reductions in hospital use is all savings, additional savings that you share between the providers and the payers. We also have quality metrics. We think quality metrics are going to be like a threshold, and the goal is we don't want people to get worse while they're trying to achieve these outcomes. So we think we're just going to measure baseline and then have them not slide backwards in terms of their quality metrics. We think practices currently don't have a lot of data on their performance. they probably don't know currently what they do in terms of ER and hospital visits. So we think there's going to be a two-phase selection process. We think practices are going to need data first on their current hospitalization and ER use. So the first phase will be to get them some data about what their current utilization is, and then from that they're able to make a better decision about whether or not this is an achievable target for them. So we think before we ask them to sign on anything and agree to pay back any money, we'll be able to give them some data. So they'll be able to understand what their goals are and how achievable that is for them. So other details, we're talking about the entire practice. There are pilots that work on a small portion of the multiply chronically diseased population. Boeing is an example. The Boeing pilot was an ambulatory, they call it an ambulatory ICU project, and that's focused on the really, really core 5% that drive 50% of your costs. It's even smaller group than that. That's a different type of pilot than a medical home pilot. Our goal is to transform primary care and to transform how primary care is paid for, which is why our pilot is going to include the whole practice site, or all the practice that the payers participate in. So it's usually written or run through the fact that the payers are responsible for the proportion of that practice's site that they have. So if a practice's site is 10% Regents, then Regents is responsible for 10% of those upfront payments and the PMPM and the fee-for-service care for that practice. We do think that coordination with hospitals are critical. Most practices don't get real-time data from the hospitals about the ER use, and that's going to be a really important piece, and a really important piece for us to evaluate when we select practices. Again, I've talked about extended hours. How obviously you attribute patients to a practice is going to be important, because a lot of times some of these patients won't have gone in to see the provider. So how they get assigned to that practice is who they get paid for, and then who they potentially get shared savings for or potential penalties for if they go to the hospital. So those things are all very critical. We also are concerned about random variation, particularly on the hospital side. With these small numbers, it's very important to try to account for random variation in some fashion. So we're working on some of the Medicare demonstrations have allowances for random variation, so we're looking at how we're going to do that. And then finally, I talked about Medicare's participation. Medicare has traditionally not participated with states, and they've done their own demonstration pilots, but they now have a solicitation out to participate in up to 6 state pilots. So they've got an application out. We think there's probably 4 states that are pretty well positioned, and that we're probably in that 5th or 6th state category. But we think we've got a good selling point in a couple ways. One is that we've got very, very strong participation from the private sector. So we've got all of our private sector health plans participating. And then 2, we've got a different model in the sense that we've got it designed with outcomes. And we think that's going to be very, very different nationally. And we think that's going to add to the literature and add to the learnings that are going to happen nationally about how to do this medical home. We've got a lot of lessons that we've learned so far. We're only halfway through it. Probably the best one, the one I'll say is that there is something in this for everybody to like and for something for everybody not to like. And it's sort of like a sweet spot, so that we're not making anybody too happy, but not making anybody too upset with us. That's what I used to say when I worked with the RSMs. So we've got a process now where we're trying to get committed to the payment model, work out all the little details that come with something like this, provide some baseline data to practices, and then hopefully have a process where we can select practices and have a pilot on the ground sometime around January of 2011. That's a lot to do, because a lot of the issues we get from the health plans are the ability to have this data available to the practices. And I think that's going to be probably our biggest stumbling block and one that's going to be the biggest hurdle for us to overcome. So I'll say a little bit about ACOs, since you've heard about ACOs also. There is legislation for us to work with a lead organization to implement 2 ACO pilots in the next couple of years. One integrated and one non-affiliated network pilot. We're in the process right now that we've solicited or sent out an RFI to solicit a lead organization. The function of a lead organization, because there wasn't a lot of state money available last year, is to do a lot of the work that would have been assigned to a state agency. So the lead organization is to do all the work around selecting, understanding, maybe even getting some grants around developing a pilot for the ACO systems, and then implement the pilots by the 1st of 2012. It's got to be coordinated with our multi-payer medical home reimbursement pilot, and so it's in the process right now, and it's also supposed to be coordinated with all the health reform activities that are going on. ACOs are going to be very important. You've heard a lot about ACOs and how they're structured. So there's a lot of interest in moving towards an ACO. The trick is going to be how do you coordinate a non-affiliated ACO and combine payment systems for providers, hospitals, specialties, those types of things. There is a role for the state. Like I said, if there is discussions about payments, and I assume that there are going to be discussions about payments within this ACO concept, the state needs to be actively involved with that and provide oversight, again, to prevent the antitrust concerns from getting too far. And with that, I will stop and answer questions. Or Barbara will come up and we'll answer any questions that you might have.
So, questions. The mic is on.
So, hi, thanks for that information. I have a question for you, though. You talked a lot about Medicaid kind of payers. So, my question for you, and our topic has been about mental health and substance use and improving care coordination and outcomes for people with those particular chronic conditions. So, do you see, or is any work being done in mitigating maybe some cherry picking on the part of these practices? Because we know that many Medicaid clients are screened out of primary care practices if they have chronic pain, for example. Mm-hmm. So are you anticipating any screening by these small to medium-sized practices for people who they may anticipate may not serve them well in terms of avoidable ER and hospitalizations?
So it's a great question, and let me use a couple examples on this. First, practices don't get to select who is in and who is out. They'll get attributed patients in their practice. So it's not an opt-in model. It's just sort of an attribution model in terms of who is in the practice. Second, there's a lot of data that we've seen around the medical home pilots that show the critical importance of behavioral health integration and coordination in care. The Boeing model showed that. The group health Factoria model has shown that. We've actually had Everett Clinic is participating in a Medicare demonstration, and the medical director of Everett Clinic has said in several of our meetings, behavioral health is the key component of being able to be successful in these projects. So I mentioned that we have these core competencies. Behavioral health integration is one of the core competencies, but what we haven't done is said, you have to do these things, because we're trying to provide as much flexibility to the practices about how they achieve these. But we will tell them, this is something that you need to be concerned about. Now, so we have included, so this pilot will include all the commercial health plans book of business. Because it includes Molina and CHPW, they've said that they're going to participate. It will include their managed care, their healthy options populations. We've had discussions with Medicaid about the fee-for-service population. Because of the transition to Provider One, they're not sure if the timing of us doing this makes sense for them, although we think maybe in the second year we might be able to do something around that with fee-for-service, but we're still talking to them about that.
So here's my ignorance showing. When you say these are going to be an attributed pilot population, is that, or patient population, is that, so if I'm a new person living in Ravensdale, Washington, and I call up the multi-care clinic and they ask me if I have chronic pain and I need a physician, and they're part of your pilot, or they have to take me in?
Yeah, if they're attributed. Okay. So there are different ways of, there's an algorithm around how many visits you've had to which providers. The tricky piece is going to be patients who have never seen anybody. And so how do you identify them and then and make an assignment of them to a PCP?
Thank you.
Yeah.
This is a follow-up, Barbara, to my question that I had before. So I had asked, because I had indicated that most, or the treatment agents that we work with, they're individual agencies, and you had said something about them becoming specialty care providers. So is that a process that they will go through, or because they're certified treatment agencies, are they already considered a specialty care provider?
They already are specialty care providers. And the role, and now that we've been through the continuum, you can see that the role that they play in their communities may vary among communities. If you go back to the all healthcare is local construct, it's entirely possible that some of those community providers may find themselves working in deep partnership with FQHCs, and in another community that won't happen. And so there will be variability about what our current mental health and substance use providers do in the future, and it'll be driven in part by what they're willing to do about stepping into new service models and by the community decision-making process about who's going to do what.
Okay. I'll stop with that because my mind starts all sorts of questions. And then I had another question is when, because a comment was made about reducing hospitalization. So I wanted to know, is inpatient treatment considered hospitalization?
Inpatient for, specifically for mental health or substance use conditions?
Yes.
Ours are going to be, right now we're thinking about it in terms of medical hospitalizations. But we haven't, I don't think that's part of what we're going to be billing for or looking at, but I'll check that out because I'm not quite sure.
Okay.
I have an observation, and that is, it is so hard to get into a hospital bed in Washington State. It's hard to think that there are avoidable ones.
That's true.
Okay, thank you.
Yeah, I think it's going to be med surg.
Other questions? I have a question for you, Richard.
Sure.
And that is, as you move ahead in the ACO discussions, are you going to encourage the ACOs to bring mental health and substance use providers into the networks?
Yes. Richard Kellogg and I had a discussion about this as we were preparing the RFI. So there is a question in the RFI about the whole spectrum of care, including behavioral health.
Great.
And what's your plan
Great.
for that?
Any other questions? Otherwise, as you can see, the train has left the station. A lot of work to do on the part of many people, but there's also a lot that's already going on. Thank you so much for being at these two trainings.